actinobacillus, which is one that accompanies actinomyces, the Citrobacter, Eikenella, and Kingella. These are, Cardiobacterium is the C. Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. These are small gram-negative rods that are not real common. They occur in the mouth and they cause endocarditis. They're treated with ceftriaxone. And then Enterococcus is usually from the GI tract or urine, but can go to the heart valves. And it's a little bit complicated because it's a little more difficult to treat because you always need to use a bactericidal drug, and it turns out that penicillin. By the way, let me just ask, what are the bactericidal drugs? How do you remember that? Well, the pharmacy school at Chapel Hill teaches that most of the drugs that are excreted through the urine, where you have to adjust for kidney failure, or the groups of drugs, are bactericidal, and most of the ones that go through the liver are bacteriostatic. So the penicillins, vancomycin, cephalosporins, those are all cidal. The ones that go through the liver, like doxycycline, the clindamycin, azithromycin, those are all static. It turns out that penicillin is only mildly bactericidal against Enterococcus, so you have to use a second drug, which is either gentamicin or ceftriaxone to treat enterococcal endocarditis. So the next group is going to be the IV drug use associated. And this is almost always Staph aureus. There are outbreaks in some cities where they've been cutting their heroin with something that with maybe water, and they might get Pseudomonas or Serratia or something like that causes it instead of Staph aureus. But for the most part, it is Staph aureus, and that's what we've been seeing with the opiate epidemic in North Carolina. And so the last one is prosthetic valve endocarditis. And what's the organism going to be with this in the first 90 days?
Epidermidis.
I'm sorry?
An epidermidis.
Oh, very good. Staph epi, because it will stick to plastic or metal. And the prosthetic valves are kind of difficult in the sense that ideally you'd like to do a valve replacement in all of these patients, but there's a reason why the valve was put in the first place. And usually they've got severe heart disease, so they're not always amenable to replacement. My father had an aortic valve and he died of lung cancer, but if he'd had endocarditis, no one would have operated on him because he barely got off the operating table the first time around. But usually it's Staph epi, particularly in the first 90 days. Questions about this list?
Do you get Candida ever on valves?
You can get Candida endocarditis. It's particularly difficult to treat because all the anti-Candida drugs are fungostatic. There are case reports of people being cured, but it's not very easy to cure them. I mean, in this group of sort of culture negative endocarditis are things like Q fever and ones like that, and they're all difficult to treat because the treatments are bacteriostatic. They're things like, doxycycline or a drug that's not very potent. So most of them need heart valve replacement. So the next question I'm going to ask you is going to be about the indications for surgery. Can everyone see that? Let me get rid of these. So what are the indications for surgery? Anybody know?
Heart failure.
Heart failure. Or
Yep.
stop.
And it's anything else?
Failure of medical treatment.
Okay.
And the size of the vegetation also, isn't it like above 10 millimeters?
Yep. I'm going to put down emboli, and then I'm going to put a space here and say vegetation over 1 centimeter, and Candida and then 6 Q fever, and some of those obscure ones. For the Candida and the Q fever, the treatment's bacteriostatic, so it's not likely to work. The problem with emboli is that people are most likely going to have an embolus to the brain. Once they've had their stroke, the thoracic surgeons won't operate on them for another 3 to 4 weeks because when you put them on the heart-lung machine, they'll bleed into their head. So you'd like to have a way of predicting who is likely to have an embolus. And we know that people with a vegetation of 1 centimeter are more likely to have an embolus. And so you would, it's basically a predictor that they're going to have an embolic event. So you'd like to go ahead and operate on those people. I have to say that compared to a few years ago, it's much more difficult to get the surgeons to operate. I have to lean on them a little bit more. You'll notice that with the exception of the vegetation over 1 centimeter, this is not based on a laboratory test. This is based on what's happening at the bedside. I might add heart block here too as one of the indications of it. But the big three are the heart failure, the failure of medical therapy, and the emboli, and then, as I mentioned, prosthetic valve. It's going to be on there as a relative indication, but it's very difficult to operate on them. Questions about indications for surgery?
If they have a prosthetic valve and you give them a new prosthetic valve, how likely are you going to get the same thing all over again?
Yeah, the surgeons are probably going to want you to clear the blood cultures before they put a new prosthetic valve in and make sure the blood cultures are negative. It is, you know, where that really becomes a huge ethical issue is in the IV drug users, because you've got these IV drug users who, if you put a prosthetic valve in, they're still using needles. If they go home, they're going to infect the next prosthetic valve. And sometimes by the time they've come in with the third time they've had endocarditis, or the second time with a prosthetic valve, usually the thoracic surgeons just say they're not going to operate on them again because it's just not going to work. But that's a big, big problem with the IV drug use population. And it's a big ethical issue with what to do with them. Okay. Any other questions about this list? Okay. Okay, so for antibiotic treatment, for empiric, you're going to, we usually give them vancomycin and ceftriaxone. I mean, this covers the haystack organisms. It covers, vancomycin covers Enterococcus, it covers MRSA, and it covers MSSA. If they've got MSSA, then they're going to either get cefazolin or nafcillin for 6 weeks. Period. And that's been pretty well studied with the work that Vance Fowler's done at Duke. MRSA, they're going to get vancomycin for 6 weeks. The other two drugs that are active against, well, daptomycin's been studied for right-sided endocarditis. I personally don't like that drug very much. They have a lot of pulmonary toxicity. Ceftaroline active against MRSA, but resistance develops quickly, so it hasn't worked very well for endocarditis. And linezolid has been used, but it's bacteriostatic, so it's not a really effective drug. Basically, the bottom line is you're going to use vancomycin for 6 weeks unless there's a major contraindication. If it's subacute endocarditis with strep viridans, the treatment is you can use either ampicillin or ampicillin plus gentamicin. And basically, how long you treat and how you treat depends on the MIC. And I just told my residents, just look this up. I mean, I would look it up. I can't remember. I look it up on UpToDate, and they're going to have a small chart there. If it's really susceptible, you can use ampicillin plus gentamicin for only 2 weeks, and you're likely to cure them. And but I would look it up and look at our MIC, make sure the MIC is accurate, and then decide on the treatment. The Hayseck organism is ceftriaxone. Does anyone know what's the big side effect of ceftriaxone when you're giving it for 6 weeks?
C. diff or low platelet thrombocytopenia?
Actually, you're correct about both of those. I'm thinking about a different one, but
Or
among
the
all the cephalosporins, ceftriaxone is the one that causes the most C. diff, but it's because it is excreted through the bile ducts, and so it gets its highest concentration in the GI tract. And when it goes out through the bile ducts, it also causes biliary sludging. So many of the patients where I've used it for 6 weeks end up having to have their gallbladders removed because of their biliary sludging from the ceftriaxone. And it's a relatively safe drug, but you just have to be aware that that's the problem. It can be associated with thrombocytopenia. That's mostly at the high doses of 2 grams every 12 hours, the dosage you would use for meningitis. Okay. Enterococcus usually use ampicillin. Now we mostly use plus low-dose ceftriaxone or ampicillin plus low-dose gentamicin. You have to use synergy. The penicillin alone is not adequate for enterococcus. Now, if they've got enterococcus from a peripenicillin abscess, then I would use, you can just treat with ampicillin alone, but it's not adequate for endocarditis. You really have to have a bactericidal drug for endocarditis. So what are the other 2 indications where you'd always want to use a cidal drug? Does anybody know? One is fever and neutropenia, and that makes the most sense because they basically bacteriostatic drugs just stop the growth, and then the immune system has to come along and clear the infection away. And if you don't have a strong immune system, if you're neutropenic, then a static drug is just not going to be adequate for clearing away the infection. You really want to use a cidal drug. The other one is meningitis, because the central nervous system has a relatively weak immune system. So it is, you can, they just do better if you're using a cidal drug. Coag negative staph is mostly going to be vancomycin. Okay. Questions about this list? My view of all of these is that, except for maybe the vancomycin ceftriaxone or maybe the treatment for Staph aureus, the rest of them, look it up, particularly the strep viridans, because there's going to be a chart in the up-to-date to tell you what the MIC is, and depending on the MIC, the treatment's very different. And if you're not good, if you don't do it all the time, I would look these up.
Can you talk briefly about indications for prophylactic antibiotics for people that already have a prosthetic valve?
Sure, and I may send you an article for it because this is shifting. Because if they've got a prosthetic valve, you're gonna give them prophylaxis. If they got a history of endocarditis, you're gonna give them prophylaxis. Many of the other ones that we've used in the past, like for mitral valve prolapse, it's not considered to be indicated, but it's controversial, and there are conflicting guidelines about it. Peter Lockhart, who's at Atrium Health Dental, is one of the world's experts on this subject, and he was on the committee that said we were doing too much. We were giving out too many antibiotics for trivial heart problems. But that said, it is so basically, I will try to send you the most recent guidelines on that, but they're much less aggressive with the antibiotics than the old ones were, if that helps any at all. I'll try to send them to you because they've changed in the last 2 years. So, good question. And I think that's most of it. I wanted to talk some about other. And by the way, the reason why it is controversial is because you can't easily do a big study. I mean, you would have to study like 100 million people, and it's not real easy to do that study. And so we're just sort of, he basically studies the normal microbes in the saliva in the mouth, and particularly the normal microbes around the time of dental work. And it's and that's where the data comes from. It doesn't come from the big studies that we actually need. I want to cover some other embolic diseases. And one of them is one of my favorite organisms, Fusobacterium necrophorum. Has anyone heard of this before? This is a mouth organism. It's an anaerobe. It produces a heparinase. It causes head and neck infections, abscesses. And because it causes head and neck abscesses, it causes emboli that go into the lungs from the neck and cause something called Lemierre's syndrome, which is basically where you have septic emboli going down into the pulmonary arteries and into the lungs. Probably about 15 years ago, I took care of a young woman who, she was about to get married the following weekend, went to her doctor with a sore throat. He thought that she had mono, which she may or may not have had. He put her on prednisone. She felt better. She got married, and then she went on her honeymoon to the Bahamas, began to feel very sick, took a plane flight trying to get home. The plane made an emergency landing at our airport, and she ended up in the intensive care unit for about a month with empyema on both sides and with Lemierre's syndrome, but ultimately survived. But all of her cultures grew up Fusobacterium necrophorum. But it's one that causes lots of abscesses because of its heparinase that it makes. Um, Bacteroides fragilis also has a heparinase, and it causes pelvic vein thromboses. And Campylobacter fetus mostly occurs in Europe. Unlike its cousin, jejuni, it causes sepsis, has a pretty high mortality rate. It's associated with farmers, particularly in the Netherlands and France. And it probably makes a heparinase, but we don't quite know. And then the last one I want to mention is COVID-19. And so we know that about 5% of the people in America admitted with strokes right now are having strokes associated with COVID-19 and with blood clots. And we don't completely understand the mechanism. I sent you one article from the New England Journal on it. But there's all these case reports of these 30-year-olds who had COVID-19. They're not feeling really sick with it, but then all of a sudden they're having strokes. And we're not quite sure why they're suddenly having strokes with it. It's one of the areas that needs research. We have probably underdiagnosed COVID-19 in the hospitals because we were only looking for pneumonia. But now that at like Atrium Health, we are now doing COVID-19 tests on everybody who comes in with strokes unless there's an obvious reason for the strokes. So we're finding a lot more people with neurologic problems like strokes. We've also seen people with Guillain-Barré syndrome with COVID-19 that we weren't expecting, but other neurologic type problems that we weren't expecting. I saw in the newspaper, they were quoting some doctor from some neuroradiologist in New York who said that he would be removing the blood clots in these young patients from their cerebral arteries, and a new one would just form immediately. And it's not completely clear that heparin and Coumadin are effective in preventing these clots. We're not completely sure how to deal with these clots. But one of the big questions and issues with COVID-19 is the whole issue of clots. And I think some of the people that are getting really sick with pulmonary complications are actually having pulmonary emboli. And the article I sent you was about antiphospholipid antibody syndrome. Most of those patients have arterial emboli instead of venous clots. So I'm not saying that I know what's going on with COVID-19 and clots. I don't think anybody does just yet. That's one of the questions about COVID-19 and clots. So other questions? So questions about endocarditis, questions about skin and soft tissue infections.
This may be somewhat related, but I've read that the Libman sacs vegetations for lupus don't break off. Is that valid? Or I mean, how do it fit into all this?
Okay. I have not seen that since I was a fellow in 1981, so I don't know. It's not very common, and particularly with the newer treatments for, we just haven't, newer treatments for rheumatologic diseases, we just have not been seeing it like we used to. Or if we've been seeing it, they've not been calling us up for the diagnosis. Whereas we get called all the time for Staph aureus endocarditis and IV drug users. I apologize for my trouble pulling things up. I needed for Enid to help me a little bit with it, but I sort of like typing it out in some ways and talking as we went along.
Dr. Horton, I have a question. For endocarditis, when when do you start looking for it? Because it seems like a lot of the symptoms are non-specific, and some of the ones that aren't non-specific, like the septic emboli, you definitely want to catch it before that happens. So at what point do you kind of become more aggressive and get the echo and start working it up?
First of all, everybody with Staph aureus bacteremia is going to get an echo. So sometimes we diagnose it that way. The people with Staph aureus are pretty acutely ill, and they've usually just had symptoms for like 4 days at the most. And they are pretty sick frequently, and it's pretty obvious that you need to be pretty aggressive about working them up. The difficult ones are the subacute ones. I mean, those are the people that might have symptoms for 6 or 8 weeks, and it's much less obvious in those people. And those are the ones where they really have the low back pain and the other non-specific symptoms, and they will have seen 3 or 4 doctors before someone thinks about the diagnosis. The vast majority of people we see today have Staph aureus endocarditis. And part of it is, I can't remember that I sent you the article by Vance Fowler. I think I decided not to because it involves a lot of the subtypes of Staph aureus and how they've changed, and I didn't think you'd be interested in that. But he did, basically what's happened is that with all the central lines we're using, we're having a fair number of people with endocarditis from central lines. And with all the IV drug use, we're having lots of Staph aureus endocarditis from that. And basically, people have better care for their teeth for the most part than they did 50 years ago. Whereas 50 years ago, it is, I mean, all those people with bad teeth, they were coming down with strep viridans or Haysick endocarditis, and we're just not seeing as much as we used to. And even when I was working the VA as a resident, we would see a fair number of them, but now the VA takes care of their teeth, and we're just not seeing as much as we used to. Other questions? Questions about skin and soft tissue infections?
I have an antibiotic related question.
Sure.
How do you approach the penicillin allergy question? And it seems like a lot of people seem to have the allergy, whether it's just a rash or not. And when do you still use penicillins versus respect that allergy?
Okay. First of all, 97% of the people that have penicillin allergy can take penicillin. Many of them were child, they had fever and a skin rash, and they basically, the skin rash was probably due to the virus and was probably not due to the penicillin, or certainly had nothing to do with it. And even the classic one, which is ampicillin with mono, we now know that very frequently it's a skin rash from mono and has nothing to do with the penicillin allergy. I'm still working in the surgery clinic, and we have our pre-op boot camp, as he calls it, and he gets people to stop smoking and to lose weight, because people are less likely to get a wound infection if they lose weight. We've done a study, and their risk of having a complication like a wound infection almost triples if they've got penicillin allergy. So basically, when I take the history, number one, I ask them, were they admitted to the hospital or the ICU with their penicillin reaction? And the vast majority of the time, the answer is no. If they tell me they were admitted to the ICU with it, then I'm really going to respect it. Number two, a very useful question is to ask if they've used Ancef or Keflex in the past. And if they tell me that they've used Keflex in the past, I certainly feel comfortable using Ancef. And if there's any doubt in my mind, I'm going to send them to the allergist before we do surgery, and they will do penicillin allergy testing for me. But it turns out that the risk is so much higher in surgical patients with penicillin allergy in terms of having a wound infection and not doing well, that it's worth pursuing, and it's worth pursuing even doing the penicillin skin testing. There have been cases where there was a woman, this is several years ago, she had Staph aureus meningitis after a neurosurgical procedure, and I was taking care of her, and she was in the ICU. She was just dying. She was doing worse and worse every day. Supposedly had a penicillin allergy. I had her on vancomycin. I finally turned to the daughter and just said, that one of the that basically I turned to the daughter and said, I need to use Nafcil, and got the daughter's permission, and the woman turned around and improved. But I did it with permission from the daughter. Other questions? I will get you the most recent endocarditis prophylaxis guidelines, because they're very different than the previous ones. And I do see a question here about syphilis and penicillin, and the and I'm gonna talk a little bit about neurosyphilis next week when I talk about meningitis. I've already worked on that some and added that to the to my what I was going to talk about for next week.
I think
Other
that's
questions?
the only example I could think of where you have to like absolutely desensitize to penicillin. I like that I've heard of. That was the main example, is if it's a pregnant woman with syphilis. But I guess I'm wondering if there are other examples where you absolutely like
That
have
is
to use a
the that is the main one, and you're going to use plain old penicillin for that one. But that's the one. Our pharmacists will do penicillin desensitization for us, and so the answer is yes. It seems like I had a different case, but we did the penicillin desensitization. But that's the main one, is probably syphilis treatment. And you don't want to miss that one with the baby. I mean, because you really don't want the baby to be born with congenital syphilis.
How does desensitization work?
They basically start at a, and first of all, I have to tell you that probably most of the time people are really not allergic to penicillin, but they start with an incredibly low dosage. There's a protocol, and the patient's in the ICU, and the epinephrine and is there in case they have a major allergic reaction to it. And you start off with a really, really low dosage, and you work your way up until they're up to a standard dosing. And a lot of times I will put them on if it's a cephalosporin, we may even just give oral Keflex at a really low dose, and the next time give 250 milligrams. And if they tolerate that, then we'll go ahead and treat them with Ancef. But both for penicillin and for the sulfa drugs, you start off with a really low dosage, and there's a protocol for it. And once you've started them on the penicillin, you don't stop it. You just continue to give it to treat whatever illness they need treatment for. Other questions about that? And any other questions? Questions about skin and soft tissue infections? I don't know what all of you are planning on going into, but if you're thinking about going into adult internal medicine or emergency medicine, you're going to see skin and soft tissue infections every single day, particularly in emergency medicine. It will just happen all the time.
Do the ED docs usually consult you for those, or they just do it on their own?
No, they do the drainage on their own. They usually handle it on their own. When we have a nurse practitioner that if the patient gets admitted with cellulitis, she goes around on all of them to see them, because it's the #1 admission where you can almost always stop antibiotics, or at least stop some antibiotics, of all the admissions. But the emergency department handles all of the little abscesses and drainage and problems like that on their own. I mean, they've called us up to help them develop a protocol, but they basically have a protocol, and they are much better at drainage. You don't want to just put a needle in there. You really want to make sort of an X mark to really make sure that it completely drains, and it drains well. So. Any other questions? And Galia, do you have any questions about the antibiotics that I sent out? Or that
No.
chart that I sent out?
I
think
don't have
that,
any questions, but I appreciate the chart. I feel like it's really helpful.
so yeah, I think the chart is, it's a useful one for you to keep. Now, it might be wrong 5, 10 years from now. You have to be a little careful, but it's probably not changed that much over the last 5 years. And we're hoping that we'll get new antibiotics in the next 5 years. So why are we having so much trouble getting new antibiotics? And also, why are they so expensive? Daptomycin is $800 to $1,000 a day.
As far as the pipeline and not producing new antibiotics, not to be too cynical, I'm guessing it's a money thing and how much it costs for research and development.
That's pretty much true. And the problem is if you develop the next Lipitor, I mean, Lipitor was brilliant because these people with cardiac disease had to take it every day for the rest of their life. Whereas an antibiotic, you only give for 10 days. And so, and they still, in each one of them, the upfront research costs are the same. It's about $500 million. And so they're going to have to try to recoup that 500 million, their research costs over that 10-day course of the antibiotic. So they're charging like $1,000 a day. Whereas with Lipitor, you could give it, you could charge, $500 or $400 a year, and sooner or later they can do the math and they're going to recoup their costs. And the other problem is that our antibiotic stewardship people, the infectious disease people, say, oh, we don't want you to use these new drugs. They'll no longer be effective, but we do want these companies to produce the antibiotics. And so we're partly at fault for not giving them the business. And in fact, we've talked about, we want to use some of the newer drugs because otherwise companies are never going to make the new antibiotics.
I have a question about antibiotic stewardship, just from your experience. If like being consulted from other clinicians, do you know what types of infections that are most likely viral or typically getting antibiotic, like which categories of infections are contributing to this stewardship problem? Is it like upper respiratory, or I guess I'm wondering just what your take on that is, like impact areas for how we could help reduce it.
Yeah, well, first of all, they pretty much, well, there are two sets of problems. They pretty much review all the antibiotics in the hospital. And the issue in the hospital is, if someone gets admitted with sepsis, they need to be treated with broad spectrum antibiotic. The issue comes up 48 to 72 hours, all the cultures are negative. It's clear they've got a urinary tract infection, and doctors are very hesitant to back down from vancomycin and Zosyn to a simpler drug that would cover like ceftriaxone that might cover the E. coli in the urine. And that's probably most of what they do. The outpatient setting is a different issue. We use a lot of antibiotics for minor problems that are probably viral. And we need a better test so that doctors in the outpatient setting will feel comfortable telling patients, this is a virus, you don't need antibiotics for it. And we don't really have that test. The viral panels are kind of expensive, and you would not do it for a routine visit in the outpatient setting. So that's the outpatient setting in some ways is difficult. And the doctors are under a lot of pressure to give lots of antibiotics. The parents come in, they really want their kids to get antibiotics. And and the guidelines are helping with that, but they're not perfect. So, other questions? Thank you, Enid. I had a little trouble pulling them up, so I just typed up the last one. I hope that was okay, but I covered the same thing. Any questions or any subjects that I need to cover that I'm not covering so far? Thank you very much. I will see you on Thursday. We're going to talk about pneumonia first, then Dr. Weinrib's going to talk about vector-borne disease.